Hello, everyone, and welcome to today's live broadcast, How to Monitor Heparin Therapy, Still a Controversy, presented by David L. McGlasson, Clinical Research Scientist, retired from 59th Clinical Research Division, Joint Base San Antonio, Texas. I am Christina Mahalik of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I'd like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the green Q&A button located in the lower left of the presentation window and type your question into the box that appears on the screen. We'll answer as many questions as we have time for at the end of the presentation. Also, please notice that you will be viewing the presentation in the slide window. To enlarge the window, just click on the screen icon located on the lower right. If you have trouble seeing or hearing the presentation, please click on the support button at the top right of the presentation window, or use the Q&A button to let us know that you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the button in the bottom left corner and follow the process to obtain your credits. Now, please join me in welcoming Mr. McGlasson. I will now turn the presentation over to him.
Thank you, Christina. And by the way, I just found out that Christina is a fellow veteran. And Christina, thank you for your service. She actually went through the base where I was working at almost the entire time of my career for the military. Today's topic, how to monitor heparin therapy, still a controversy, is come up because there are a lot of people who are still confused about whether to use the anti-factor Xa or the APTT test for monitoring heparin. I'm going to take you through quite a few things today, some research that I've done to support the thing, presentations and manuscripts that are out there that gives pros and cons on both sides of the issue. It's come up because a lot of the places that have been doing like anti-factor Xas for a long time to monitor heparinoids have switched back to the APTT because of a change of staff and personal opinion by particularly surgeons in this area who are monitoring their patients in the OR. So is the chromogenic anti-factor Xa assay less affected by pre-analytical variables in monitoring patients on unfractionated heparin and low molecular weight heparins than the APTT? Well, that's what we're going to be discussing today. The APTT has been around a long time, since the late 50s. It was the most commonly used test to monitor unfractionated therapy, but you can't use it on any of the other heparinoids, the low molecular weight heparin variety. The therapeutic range came out to be 1.5 to 2.5 something. That was brought up in 1972, and you don't know whether it's the mean of the normal range, the geometric mean, whether it's part of the range. It never has really fully been explained, but it does correspond to what is considered the therapeutic range of unfractionated heparin, which is 0.3 to 0.7 units per ml. And that's assayed by the anti-Xa test. Previous studies have cited the interference of a lot of things you see here, the oral anticoagulants, birth control in the form of oral contraceptives, lupus anticoagulants, factor deficiencies, acute phase reactants, fibrinogen factor VIII. Specimen collection is one of the biggest problems. Low antithrombin levels. I picked that up early in my career. I did the first antithrombins, I think, in Texas back in the mid-'70s. And we found some people, a few docs came down and says, our heparin's not working. You guys are doing something wrong. And I said, of course. Have you checked the antithrombin level of the patient? What's that? Bring him up to speed on the antithrombin and found out we had a whole family that was antithrombin, we called it 3 back at that time, deficient. The PTT reagent itself, is it a lactic acid? Is it a particulate activator? Can play a big role in monitoring heparin. And the instrumentation, mechanical versus photo optic, can be a big issue. Now, anti-10A interferences are things like, you'll see them a lot in, especially in neonates, hyperbilirubinemia, hyperlipidemia, which can be cleared with ultracentrifugation, and the anti-10 assay can be used to monitor all heparin analogs and unfractionated heparin and the direct oral anticoagulants, which I use the acronym DOACs at. One thing about the hyperbilirubinemia, I got a question when I gave a presentation at AACC this summer, and someone said, what happens when you're using TPA, the tissue plasminogen activator? In other words, you're working with clot bustings. It comes down to the laboratory totally red. And that's an answer that I have not been able to find out what to do on that. You could probably try diluting it out with a normal plasma and then possibly going by the dilution, but I'm still gathering information on it. If anybody is having that issue, I'd like for them to contact me to see how we can counteract that. Now, the therapeutic range we already discussed for unfractionated heparin, and for the low molecular weight, it's 0.5 to 1.1 or 1.2. People vary on that, depending on the institution. Unfractionated heparin itself works with antithrombin, which is a natural anticoagulation protein. Whatever starts the coagulation mechanism, you got to have something to shut it down, and that's one of them. The heparin binds with antithrombin. It changes the conformation of both reagents where they lock together, and it increases the anticoagulant activity. Heparin by itself won't work without the antithrombin present, or it's extremely slow. So it speeds up the inactivation of thrombin at that point. And it slowly it slows the coagulation activity primarily by inactivating thrombin, which is 2A and 10A. It actually does work somewhat throughout the entire coagulation cascade where you have activated systems, but primarily the 2A and 10A are the most explosive in what's measured. And heparin approximately equally binds 2A and 10A. A little bit difference, and if you're using a kit, I strongly invite you to use the ones that are 2A activated, 10A activated for when you're dealing with some of the kits that are out there. 2A is a little bit unstable. Now, why do we monitor? Well, there's a wide variability of heparin activity in everybody. It has nonspecific bindings to plasma proteins, blood and endothelial cells. It can bind particularly to fibrinogen and factor VIII, the acute phase reactants, and which when elevated will decrease the effectiveness of heparin and the APTT times. In other words, you've got an elevated fibrinogen, and I'll show you some of this a little bit later on specific patients. It will depress the length of the APTT, make it a lot shorter. And there's a big reason, particularly, this is the weight-based medication that is used in anticoagulation activity. You've got to know the patient's weight exactly. And due to a difference in body mass index, a story I can tell you very quickly is when I was doing a research protocol, which I'll be talking about a little bit later, one of the problems I had, I wasn't getting the heparin that I thought I was supposed to be getting according to doses that the patient allegedly was supposed to have. And the pharmacist and I both checked everything out. Yeah, everything was working. We sent our stuff to other laboratories. They sent it back, to the companies for analysis. And we got what we were supposed to. What we found out was that the nurses on one unit or the personnel on one unit were not actually weighing the patients. They were taking their word for how much they weighed. And one patient that told me she weighed 160 pounds, I gave her kind of the stink eye, and I said, really? And she goes, honey, if my husband knew how much I weighed, I'd really be in trouble. Now, that's not taking a shot at gender or large or people who are a little bit overweight, but we've got to know exactly how much they weigh in order to give the right dose. Also found out that sometimes, particularly with unfractionated heparin people that are on an IV, if they were being sent to the clinic, they were being disconnected, they'd missed their dose, and they thought, oh, well, we'll make it up later. So you've got to really be able to work with your pharmacy, floor personnel, and the laboratory all together to give the physicians the proper results they need to treat the patients. And different diseases can cause the issues also. Its uses are, it's primarily there to prevent the treatment of spontaneous or iatrogenic venous or arterial thromboembolism, and that's something, the iatrogenic is what's caused by the procedures that you're doing. If you're having open hearts, you really want to know what your heparin levels are going through there and how it's being handled. Decreased morbidity and mortality associated with thromboemboli disorders, of course, your deep vein and pulmonary embolus, MIs, unstable angina, coronary angioplasty, bypass, which I've been on when I had an aortic valve replaced. So I was very happy that they were getting it, I was being anticoagulated properly. ECMO, which is used a lot, particularly in neonates that are born prematurely. Stroke and transient ischemic attacks, heparinoids are used then. And then later they're switched over to different medications. One thing about unfractionated heparin is it's not very portable. It has to be treated in the hospital usually. Okay, so how do we monitor it? Well, the APTT has been around forever, and it's what people are used to. And if you learn it in medical school, I'm not going to change. That's some people's attitude, not everybody's, but it's a problem in communicating with people on, we've got new updates. The goal, 1.5 to 2 times the mean of the control value. We talked about this, and being equivalent to the 0.3, 0.7 units by the anti-Xa. The intent is to become therapeutic within 24 hours. If you've got your subtherapeutic during that initial period, you have a statistically high problem of having a BTE reoccurrence. And it's also very clinically important. The dose actually may be more important than the APTT in predicting the clinical efficacy if they give it, without measuring it. Sometimes that has to happen if they don't have the availability they should. There is a balanced risk between clotting and bleeding with this drug also. The relationship between supertherapeutic APTT and bleeding is less clear. In fact, I once had to testify in a serial killer nurse case that's coming back in the news. A lady by the name of Janine Jones was responsible for possibly injuring or killing as many as 60 patients, and I had to testify on the second one that she was tried on. And the grand jury asked me, they said, well, what about if the dose is too high? How can you tell when they're going to bleed? And I said, that information is not out there. We don't know because everyone individually is different. And we just have to see what's going on. We have specific levels that we look for as being critical, but as to know when they'll start bleeding, that isn't clear. And I haven't seen the publications out there standalone that will give you that information. Okay, monitoring heparin. There are hemorrhagic complications due to underlying clinical morbidities. And when you're dealing with a large hospital population, you're going to see everything. I've listed several of them here. The one that troubles me the most is the age greater than 65. They seem to stamp that on everything. And since I'm older than 65 now, it's something that you're immediately classified as. But as you can see, a lot of things can also interfere with it from a treatment standpoint. You got to weigh the risks. Factors affecting the APTT. First off, the pre-analytic variables due to patient or sample collection factors. And that's something I'm going to talk about in the research protocol that I did that we published a couple of papers on about how the pre-analytic variables really affected the testing. And it also would have affected the physician's treatments. When I showed them the data, I said, what would you do with this APTT result? And then the analytic variables themselves due to the processing and testing in the laboratory. And we're going to talk about some of those. Pre-analytic variables, sample volume. The 9-to-1 blood to anticoagulant ratio is pretty critical in monitoring the APTT. Not so much the anti-Xa, which we'll see a little bit later. Transfer and storage time. Within an hour of the collection, and we'll specify this a little bit later, you should have that sample spun down and separated. If it's over 4 hours still on the cells, forget it. If it's over 4 hours from testing and it has not been frozen, or if it hasn't been frozen and then rethawed properly, you're going to have a problem there. The citrate concentration, 3.8 versus 3.2. Well, in this country, we pretty well established the fact that 3.2 is the way to go because it more closely represents the physiologic situation in the blood. But in many foreign countries, they're still using 3.8. So you might run across that. The patient hematocrit, if it's greater than 55, you have to make an adjustment on the amount of citrate involved. And the interfering substances that we talked a little bit about earlier, hemolysis, the icterus index, anybody remember that test? And lipemia. And with lipemia, you can sometimes do something about, but not always. All right, other factors affecting the APTT. Centrifugation speed. I got burned on a research protocol that I was doing one time because 2 laboratories were processing the samples, and I found out that the G-force on one centrifuge was different than one was on the other, and I was getting residual platelets on one, and when the samples were thawed out, that was releasing platelet material in that was shortening the times on the assay that we were using. You got to check it every 6 months to make sure you're getting a residual platelet count of less than 10,000. More platelet-free, the better. Also, residual platelets can release PF4, which is your platelet factor 4, which is your neutralizing heparin reagent. Type of reagents that you use. The concentration of the calcium chloride varies from vendor to vendor. Each particular lot number will give you a different assay with the APTT. The time to testing, we just discussed that. 1 hour to process, 4 hours to test before freezing. Ideally, -70 is the way to go. Did a study early in my career where everybody was saying, well, what should I keep this in at? Can I keep it in the refrigerator overnight? Can I just put it in the refrigerator freezer? I've got a -20, but I don't have a -70. We did some small studies on that and found out that -70 was the best way to go. Anything below -50 is good. If we found that sometimes in a week's time storing at -20, we lost as much as 50% activity in certain specimens, even at -20. So -70 is the best way to go. Thawing method, 37 degrees for no more than 5 minutes. Some of the factors are thermolabile, particularly factor 5 and factor 8. And you can lose activity there if somebody forgets and lets it sit in there for about 30 minutes. All right, other variables that affect, that may cause an elevated APTT. The patient's already on heparin, direct thrombin inhibitors, the direct oral anticoagulants, warfarin or Coumadin. Warfarin, one study showed that the APTT prolonged about 16 seconds for each 1.0 increase in the INR. That's a few years ago, but when the INR goes up, you've got factors that are being decreased that will be picked up in the APTT, particularly the vitamin K dependent factors like factor 9. So you're going to have elevations and problems there. Factor deficiencies such as hemophilia, von Willebrand disease, factor 11 will increase it. Now, ones that don't increase it, bleeding risk, but will still cause a problem with the APTT are your lupus anticoagulants, factor 12 deficiency. In fact, the person who the factor 12 is named after actually died from a thromboembolus. Prekallikrein and the high molecular weight kininogen, or the Fitzgerald factor, will also cause an elevated APTT, but will not increase your bleeding risk. Now, monitoring the heparinoids using the anti-factor 10A, it's used to test the unfractionated heparin, and it's the only assay for monitoring low molecular weight heparin, such as enoxaparin, dalteparin, tenzaparin, nordaparin, fondaparin, or the direct oral anticoagulants, with one exception on the direct oral anticoagulant. It will not let you monitor Pradaxa or dabigatran. And why is that? Because it's a 2A affected direct oral anticoagulant, and all the rest of them are 10As. The commercial names for enoxaparin are like Lovenox. For dalteparin, it's Fragmin. For tenzaparin, it's Inohep. And for nordaparin, it has two. It's Fraxaparin or Pradaxa, depending on where you are. Now, you can use a single calibration curve or a universal hybrid curve with universal calibrators, with one exception. Each with, well, actually two. The fondaparin or Rextra, it's a pentasaccharide that does not quite act like the other heparinoids do. And so you have to use a single calibrator for that. And also for each of the direct oral anticoagulants, there is no universal calibrator for those. You have to use a anti-10A test with a specific calibrator for that. Now, one of the problems that we had when we first started doing anti-10As, and still do, is somebody sends down a request for a factor 10. This is a big communication problem, and it actually started me on one of my research projects because I could not get, we needed to know, you know, like, okay, you really want an anti-10A, you don't want a factor 10, but we need to know the type of heparin it's on. And when I called the unit, I asked the responding RN, I said, so you guys really probably don't want a factor 10 activity That's a real rare bleeding deficiency. Is the person actively bleeding? No. I said, so do you want something for anticoagulant like heparin? Yes, heparin. I said, okay, what kind of heparin? Heparin. No, is it unfractionated? Is it one of the low molecular weights? It's heparin, and hung up on me. I go, wow. So we had to go to the, had to send the pathology resident up to the unit to find out what type of heparinoid it was, and I thought, you know, the lab shouldn't have to guess. We should just be able to run the assay and give the information back, and they should know what type of heparinoid they're on. But the chromogenic factor 10 assay is an awesome assay if you're monitoring somebody who has something like a lupus anticoagulant and you're putting them on like Coumadin, and you need to monitor and it's interfering with the PT and the PTT, and you need to monitor what's on. And one of the papers that I wrote a few years ago, and Terry Rossborough has also written some stuff on this, and as well as Stephen Mall with Tom Ortel at Duke, where they used to be, where you can use the chromogenic factor 10 assay, and it has no interferences by those other methods. In fact, it's more accurate than the INR. It's accurate because the INR, once it gets above 4, is woefully inaccurate, and you can have people with factor 10 levels with a that are like 40% when they have an INR of 12.5. So if you want some more information on that, I can provide it to you later. But I know that everybody has experienced this problem of getting a factor 10 when they really want an anti-10A. That's why I kind of threw it in there. Now, here are the advantages. It's not susceptible to interference from any of the acute phase reactants like fibrinogen or fibrin. It's not influenced by any of the factor efficiencies with the exception of antithrombin. If it gets below 50% activity, I have not seen a method yet where it hasn't been affected that where the antithrombin has to be added to it. Even some of them where they add antithrombin is a problem. Most of everybody is going to the non-antithrombin kits when they're using the antithrombin assay. So the patient's plasma furnishes the antithrombin that is evident that's needed in there. Now, it's not affected by underfilled collection tubes or citrate concentration. I'll show you this a little bit later, where we purposely used a 6-to-1 versus the 9-to-1 anticoagulant ratio, citrate 3.8 versus 3.2. So it's no longer necessary to establish an APTT therapeutic range, which is extremely laborious, time-consuming on collecting the samples and the availability of the samples. And you can check the reference there, blood coagulation and fibrinolysis. I'm the author on that. Advantages using the 10A. It gets you in the heparin therapeutic range faster. That's a big plus. Less testing, less dose adjusting, less blood draws. Study using 268 subjects on unfractionated heparin and randomized into 2 groups for 10A or PTT testing. You can see that the people in the 10A group in range are 67% of the time in the heparin therapeutic range, and the PTT group only 33% of the time. Very interesting thing also is in Coumadin. One of the problems with that is it depends on where you're at, but Xarelto or rivaroxaban was held up because the test group that they used to monitor against only had 58% of the people in the therapeutic range of 2 to 3 during the study. And that is abysmal. In our Coumadin clinic, which used to see about 3,000 people, I don't know what they're seeing a month. I don't know what they're seeing now. If we got below 80%, we felt like we were doing something wrong. But across the country, the average was about 55 to 60% of being in the therapeutic range. That's how hard that drug is to control. And a subsequent study by Dr. Rossborough also showed in using a dosing nomogram, which he was the person given most of the credit for coming up with the best dosing nomograms for the heparinoids, showed that the anti-10A range got you there in 16 hours in 80% of the subjects and 87% at 24 hours. PTT doesn't even come close to that. As you can see down in the next study, it only got to a 43% range using the APTT only, with longer times to reach therapeutic levels in 24 hours. Now, most of the anti-10, well, several of the anti-10A tests that are out there now have a liquid assay format where you don't have to reconstitute anything. You can just pull it out of the refrigerator, slap it on, and get it ready to go. Long stability time, most of them are up to about 10 days. No reconstitution, as I said, necessary. It reduces reagent waste. You can have it on the machine longer. You don't have to toss it out daily. You don't have to have somebody mixing it back and forth, pulling 10 mLs out here and adding 5 mLs back and all that type of stuff, or reconstituting the lyophilized reagents. And with the PTT, there are some that are still lyophilized. A lot of them are liquid now, but it's still an issue. You've got to take time to put it together, and you still always have the advantage or disadvantage of human error there. So it also eases storage issues, a more precise measure of with the anti-10A than the APTT gives you. And it reduces, that's one thing that has just come out recently, and Belk in 2016 saw that it reduces blood transfusions in different disease hemorrhagic states from 4.7 to 17.5%. That's a big saving on money, and it's a lot easier on the patient because we found out that blood transfusions don't they're not exactly benign like we think they used to be. In fact, I refuse to have blood products unless it was absolutely necessary, life-threatening situation. I went on that with my surgeon, and she said, fine. And she said, you got down pretty low on your platelets. You were at the 41,000. She said, another 11, you'd have had a six-pack. And I thought, interesting. Glad I escaped that. Monitoring unfractionated heparin with anti-10A, the rationale for change, cost. I'll give you specific numbers in dollars and cents a little bit later. But it gives you a shorter time to the therapeutic range. As you can see, within 6 hours with the anti-10A, within 6 hours, 54% were already there versus 27% for the APTT. Within 24 hours, 74% versus 63%, and less dosing changes. It's almost twice as much, 1.7 versus 1 for the APTT over the anti-10A. Now, when do we monitor the low molecular weight heparinoids? It was brought out there like so many of these other drugs, like the direct oral anticoagulants. Oh, you don't have to monitor this. Oh, you don't have to measure this. Oh, except if a few special situations like they talk about, overdose, pregnancies, extreme body weights, high or low, children and renal insufficiency. And we've also found out there's been some talk at some of the meetings that I've attended in the last couple of years that all diabetics that are on the low molecular weight heparin should be monitored. They found out that they had better outcomes with that when they're having to use heparinoids if they monitor them. So they're a lot more effective than unfractionated heparin in preventing and treating deep vein thrombosis. All right. Monitoring unfractionated heparin with the anti-10A, the rationale for change. We already talked about that in anywhere from the average of 28 hours of anti-10A versus 48 hours of the APTT. More test results were within the therapeutic range, 66 versus 42. And less rate changes within 24 hours, 0.8 for the 10A and 1.6 for the APTT. Now, this was another study by Gravel, who published it in the Annals of Pharmacotherapy. So you've seen about 4 different studies where the anti-10A comes out much better every time, and there is efficacy to back this up. Now, the ideal assay is what you see before you. Linear assay, the APTT is not linear in any way, shape, or form. The precision, okay, if you get 10%, you're really doing good. You should get around 5% depending on what you're using, but it really matters what your reagent instrument combination is. Is it standardized? No. You don't even have an ISI value like you have with the INR, even though there's been an attempt ever since it was invented to standardize it. It's just not there. Is it readily available? Yes. Is the heparin anti-10A? Yes, it is readily available, but a lot of laboratories aren't set up to use it. And I have mixed thoughts on that, but you know, if you're going to be giving out heparin, you should be able to give them the best test available to treat the patient, or have a laboratory you can send it to very quickly with a good turnaround time. Inexpensive, we'll talk about that. You know, yes, the APTT is. Everyone thinks that the 10A is too expensive, but when you add all the factors in, which we'll discuss, it's about the same. It's within cents of one another without the hassle of having to re-standardize it. And I'll tell you, the calibration curves on the anti-10A, the one that I use, I only had to recalibrate twice in 6 months. That is incredible. Also, when I compare it to other vendors' reagents, they almost always come out exactly the same, yet the PTTs, when you compare the difference in reagent instrument combinations, it's all over the place. So 10A is more standardized. All right, now I'm going to talk about a research protocol. I published 2 papers on this, one in Lab Medicine, and the other one in Blood Coagulation and Fibrinolysis, where we had a group of patients that were receiving low molecular weight heparin or unfractionated heparin, and they were consented for the study. We went through the local institutional review board, through the Helsinki protocol, and it was monitored through the Surgeon General's Office of the Air Force, who was also then monitored by the Surgeon General of the United States. 26 subjects were receiving low molecular weight, and 20 individuals were receiving unfractionated heparin. Actually, I went over that amount, and I got called in front of the IRB wanting to know why I'd exceeded my value. And I said, well, I sent you an amendment. You guys just haven't got it yet. But the reason was, it's what I discussed earlier. I was finding people that were supposed to be on heparin who were showing no heparin at all or extremely low levels. And we finally found out why. Issues of the patient not being there, skipping the dose. And I found out that 8 o'clock meds didn't necessarily mean 8 o'clock. There was an hour-and-a-half window in there where they were giving the drugs out. And they're looking at me like, okay, so we need to tighten up a few things back at the units. It's really not the fault of the units. What it is you've got a drug that has to be handled properly. Proper weights, proper nomograms for it have been spelled out, and also the proper times to give it and testing. You've got to test it within a certain time period after you give it. And so then you've got to know when was the person actually dosed to give proper units, because then you might give them too much next time or underdose them the time after that. In our study, we looked at a full range. Anything, by the way, in the range assay for the unfractionated heparin, anything below 0.05 is essentially noise. All the manufacturers will tell you that anything below, that level, pay no attention to, because it really isn't an accurate value. The low molecular weight subjects were anywhere from 0.06 to 1.22, and you can see the wide range that you have up there in the ages. The 20-year-old actually was a person who was an Iraqi war veteran who I said, kind of young to be on heparin for a pulmonary embolus. He said, yeah. He said, unfortunately, I was using a heavy piece of equipment to dig into a mass grave burial site, and they booby-trapped it with sarin gas. And it affected my lungs, and I had a pulmonary embolus before they got me out of there. And I'm thinking, wow, I'm glad that we have heparin and we're able to treat you, but thank you for your service. So when you work for the military, you see things that other people don't see, and it's, like I said, I was glad that he got back safely, but he was the person on that study that who was the 20-year-old at the time. Pre-existing conditions included but not limited to coronary artery disease, antiphospholipid antibody syndrome, deep vein thrombosis, recurrent spontaneous abortion. I got the good luck to be in one of the first groups that started using low molecular weight heparin and aspirin to get people through a full term of pregnancy. We had a group of individuals that we had 16 of them who had never been able to carry past the first trimester. And we found out that almost all of them had an antiphospholipid antibody syndrome, lupus anticoagulant. And they'd never been able to get through. They tried them with prednisone and aspirin and what have you. Well, they started using the low molecular weight heparin, and they were monitored each step of the way on each visit that they came in. They were administering their own low molecular weight heparins at home, and they got 14 out of 16 through full term. That's pretty cool. And also pulmonary embolism can be an issue. Also, a lot of the subjects were also taking oral anticoagulant therapy. Each subject, we drew 6 tubes obtained in what I hope was a single atraumatic venipuncture, because I collected about 90% of them. And then we split them into 3 groups, 3.8 versus 3.2 sodium citrate, and a CTAD tube, which I don't know if it's still available in the States. It stands for citrate, theophylline, adenosine, and dipyridamole. These were all obtained, I think we used BD at the time, that tube was supposedly one that has the most damping effect on the release of platelet factor 4. And we took a look at that as well in our study, and I'll show you those results a little bit later. We each they each had a tube drawn, a normal draw of 9-to-1 blood to anticoagulant ratio, and a short draw of 6-to-1 to see if this would have an effect on the anti-10A. We used descriptive statistics, the t-test, or the analysis of variance and linear regression in our statistical evaluation of the study. Platelet-poor plasma was obtained by, we centrifuged at 2500 G and G-force, or your RCF, for 15 minutes. We went a little bit longer than normally do in the lab. Usually most people use 10 minutes, guaranteeing a platelet count of less than 10,000, and each sample was checked for that and stored at -70 degrees until ready for testing. All specimens had an APTT and a chromogenic anti-10A performed on each specimen, regardless of the type of heparin being given. And each specimen had an anti-10A result for each calibration curve, the unfractionated, the low molecular weight, and a hybrid, or now most people are calling it the universal calibration curve, with the anti-10A test. The APTT reagent was the PTTA reagent from Diagnostic STAGO. Now, this test, the rotochrome heparin assay from STAGO, has been reformatted and is no longer called that. So STAGO is selling it under a different thing. This is one where the antithrombin is not added. The analyzer was an STAR automated coagulation analyzer. I think it's now called an Evolution Plus Max. All the collection tubes, of course, were the standard non-wettable siliconized, all obtained from BD. Now, here are the first results on the unfractionated subjects using, that was analyzed using the analysis of variance, which will give you the descriptive statistics and your F value and primarily your P value. Less than 0.05 is statistically significantly different. As you can see here, starting here and going straight down, the values are really tight, regardless of 3.8 normal draw, 3.8 short draw, 3.2 normal draw, 3.2 short draw, the CTADs, normal draw and short draw. The APTTs, very interesting. You can see the worst one here was 127.2. Strangely enough, the rest of these came in to where the ranges were sort of close out there, very elevated. And, you know, our normal range is usually about 28 to 35, depending on your reagent. And the p-value was 0.9481, so we had good agreement. But this can really fool you. I'll tell you why. If you use something called a cumulative summary, you might get a mean sometime of 60 seconds where the range is 40 to 90, and then you'll get the same range of 60 seconds where the range is 35 to 70. You can be fooled by that. And so you want to look at, though, at how close the anti-10A testing values were. Now, in this group of patients here, this one, let me see, 62.8. This one, and down here at the bottom, the 62.96. So you've got 62.84. This patient here, and for the sake of everything, we'll go by the PTT reagents here. And this is the normal draw, 3.2%. I handed these to one of the co-authors on this paper, Dr. Rich Krasuski, who has gone on to become very well known in the area of cardiovascular research and clinical treatments. I said, okay, what would you do with this patient? He said, oh, I'd give him more heparin. That PTT is way too low. And on this patient here, I said, what about here? That's 35.8 seconds, by the way. And he said, I would definitely increase that one. And I said, what about this one here? With, you know, look at this here, but with this here where you got 91.6 seconds. He said, I would probably leave that alone or cut back a little bit. And I said, fine, Rich, you would have screwed up 3 patients. Because look at what their chromogenic anti-10A levels were. This one up here had an elevated fibrinogen of about 600. This patient had an elevated factor 8 level that was around 180% activity, and the bottom one down here that has 0.05 is a lupus anticoagulant. That's why you had extremely long PTTs, and the anti-10A test, was not working properly. So that you can see on actual patients the problem. Now, the anti-10A APTT results on low molecular weight subjects, you can see here, again, we saw similar values. The p-value is 0.9059. This is what I wanted to show you here is you're not supposed to use the PTT for low molecular weights, but look how it will affect the test. It's slightly prolonged every single group. Now, it wasn't statistically significantly different, but the prolongation was there. Okay, the single versus hybrid curve. Now, I hope you can see here. Here we had the unfractionated calibration curve, and here we had the hybrid curve. So you got specifics, and then you've got here the low molecular weight calibration curve, and again, you've got the hybrid curve up here. We've got very good correlation here. Up here, it's like 0.95, almost 0.96, and here 0.9854. Extremely close. No difference between the individual calibration curves and the hybrid curves. Very good correlations there. And we went on to use another company's reagents. ANIARA was this one, and where we ran 50 samples that were randomly picked over the range of the study. And we saw, again, using the single calibrator on both of them and a hybrid curve, there was no statistical or clinical difference. P-value was 0.88, really close and very good. This is, again, using the low molecular weight heparins, doing the same thing. The last one was, of course, the unfractionated heparin. This is the low molecular weight. Again, very good comparisons, and a p-value was 0.6, and that was because of the spread of this, but it's still not statistically or clinically significantly different, as you can see here. Great correlation. And this is where we use two different lots of ANIARA's reagents, and this is actually, ANIARA is the distributor, Biomed is the company that puts out that reagent, and great group of people to work with, just like all the vendors that I've worked with, frankly. They're always great to cooperate. And again, you see here, here's two different lots where we use the unfractionated hybrid curve, on the hybrid curve with unfractionated heparin, very close, good p-value. And you can see the comparison here, great correlation. Your R-square is 0.95 for your unfractionated, and the low molecular weight, your analysis of variance here, not significant, 0.99. You can't get much better than this on the spread. And this is comparing the rotochrome heparin assay versus the biofin method. And this is one which shows you the discordance of the anti-10A versus the APTT. A really good study by Price back in 2013. You can see the spread in here. This is your low anti-10A prolonged PT and your high anti-10A with low or normal PTT. And this was what he got on it. He found that the discordance was 43% of the time with the anti-10A range and the PTT above the therapeutic range. Most of them were on simultaneous Coumadin, and they had an elevated risk or major bleed and death, and you can see the comparisons down here where you had, he looked at 2,321 paired values from 539 subjects, so he had a lot of power in that study. And you can see in the boxes here where, for example, let me get the arrow in here. Like here, you see 15 patients that had major bleeds in 21 days, 2 consecutive long PTT versus in-range anti-10As. In other words, the PTTs were out of range, the in-range anti-10A on 163 subjects. Here, again, you see a long PTT versus in-range anti-10A. The number was 85. and you can see the differences between the two. And again, out here where PTT was in range and the anti-10A was concordant, very low percentage values here in comparison. That's a lot of people that's being measured there. Okay, conclusions. The anti-10A heparin results were not statistically affected by any of the collection tubes or the blood to anticoagulant ratio. Individual APTT results in the anti-10A assay showed a high degree of discordance, and this can lead to inappropriate heparin management. In the 3 published studies, the rate of discordance was 43 to 58%. Big difference when you're comparing PTTs versus the anti-10A. Okay, the anti-10A to reach therapy in another study that Richard Marler just published in Seminars in Thrombosis and Hemostasis. They used 1,690 units per hour versus the APTT, which used 1,884 units per hour. Less heparin, more heparin, you see here. The group managed by the anti-10A testing were in range while the APTT mean subjects remained subtherapeutic. The anti-10A reached therapeutic levels in 16 hours in 80% of the subjects and 87% in 24 hours versus 20 hours longer with the APTT. And the cost over 4 days of unfractionated with the APTT was $27.10 versus $31.46 for the anti-10A. When labor costs are factored in for phlebotomy, lab labor, dosing adjustments, the cost for anti-10A testing is cost neutral. So that old bit about, oh yeah, it's too expensive. In the long run, it's not. You get a better number for the doctor to treat the patient with. The patients aren't hassled as much. The nurses don't have to make the dosing adjustments as much. And the laboratory doesn't have to make the collections and the testing as much with the anti-10A. And here you see a comparison of the APTT values to the unfractionated values. This is also in Marler's study. And the shaded areas here show that in this study with 2,187 patients, the patients were in range when you compare to the APTT versus the concordance with the anti-10A. It only compared 58% of the time. So you got issues. How do we handle all these and do them all at one time? Now, I'm going to be using some slides here that I got from a different source that I have had to work with, where they calibrated with different low molecular weight heparins. And as you can see here, when you compare each one of these individual calibrators with the different drugs that we talked about earlier, low molecular weight heparins, there's absolutely hardly any difference here in the calibration. Very nice, very linear assays. Okay? Here, using the universal calibrator with a new type of reagent with that, again, we are able to monitor all of the different heparinoids that you see here, unfractionated, low molecular weight, individual curves on all of those, the Lovenox, the fragment, the NOHEP versus unfractionated. Using the universal calibrator, the curve is a little bit different, but that's just the instrumentation and the reagent that was used on this. That slide's actually, this one was from IL that furnished this one. I saw it in a study a couple of years ago, I think at a Quest meeting in McLean, Virginia. Now, this is using the universal calibrator curve here. Here are the target values up at the top. And you see here, look how close all these values are, going from here down. These are the target ranges that you're seeing in this range here. And in each one of these, you can see that they are recovering almost the same thing all the way down, all the way across. So very good close correlations with the anti-10A testing on all of the different heparinoids using the universal curve. So now we don't have to guess. We don't have to worry about what the floor is sending down. We can run a universal method, one curve, one stored, not 5 or 6 like it used to be, and you can get good results with it, the same as you would if you were running a single calibrator. Okay, this comes as close to the end of the presentation. What do we do? Well, I threw this slide up at the Greater New Orleans Coagulation Conference that they used to have in New Orleans, a great study by coagulation consultants, laboratories down there, Dr. Gloria Coker. And I had a large audience of about 400 people. Several of them were the physicians. Several of them were pharmacists, nurses, medical laboratory personnel. I said, what do we do here? We've got a PT of 26.3. We got an INR of 2.3. We got a PTT of greater than 200 seconds. And our anti-10A value is in the therapeutic range of 0.3 to 0.7. This is on a patient on unfractionated heparin. Almost everybody said, nothing, don't do a thing. The anti-10A, something else is interfering here. The anti-10A test, we would go with it. So, here's what you have to do if you want to do the PTTs. Again, this just, like I said, this just came from Dr. Richard Marler's paper in 2017. It used to be we had to use 60 samples. 60. That's a large number to get. They all had to be individual. You couldn't use the same person twice, blah, blah, blah. They all had to be processed in a certain way. Do we test fresh? Do we test frozen? It was a problem. Here's what he has spelled out. Collect appropriate number of samples. Now, this is out of the CLSI manual of, with the H21 number. Determine the APTT on fresh samples. Determine heparin level on fresh or frozen samples. Plot that against the heparin level on the x-axis and the PTT on the y-axis. Determine the best fit line using linear regression. Determine the APTT value for both 0.3 and 0.7 units per ml. The heparin therapeutic range and the PTT range is between 0.3 and 0.7. And all data and calculations must be available for evaluation. But you still got to use the 10A. So why go? You still got to use the 10A to establish this method. So if you've already got it available, use it. I might be going against current theory by some people, but I've seen it in practice. I've seen it in research, and I've seen it in the any clinical situation you could possibly imagine. And if it was me as a patient out there, I would want them to be using the 10A to monitor me. Thank you for your time. If there are any questions, I'll be glad to answer them now.
Well, thank you, Mr. McGlasson, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the green Q&A button at the lower left of the presentation window, type your question into the box that appears on your screen, and click on the send button. We'll answer as many questions as we have time for today. So let's get started with our first question. This question asks, so are you saying that you can use the anti-10A assay for measuring the DOACs?
Yes. The direct oral anticoagulants that are out there now, such as rivaroxaban, apixaban, edoxaban, betrixaban, there are several that have a ban to them, and all of them, with the exception of the dabigatran, can be used, the anti-10A test with specific individual calibrators can be used to monitor the direct oral anticoagulants. And we're getting into situations now where we're finding out we have to do this. I had a call from a friend of mine who's an anesthesiologist, and he says, okay, what is a apixaban or rivaroxaban? And I said, what do you got? And he said, I got a guy on the table bleeding. And he said he came from your shop, and they said he was on Coumadin, and but he'd been taken off. But they didn't tell us he was on this other drug. And I said, okay, call your pharmacist, number one, and number two, you know, you're going to have to put on stabilizers until that wears off because it doesn't have an antidote. But he said, well, how much have I got on board? What test can I use? And I said, we don't have one in the United States, anything but RUO, so you're going to have to use probably the PT test to measure it. And he said, gee, thanks. What about the PTT? I said, good luck. That's where we were a few years ago. Now we know that there are certain situations. What if you're in an accident and you come into the ER and they don't know, you know, when's the last time you took your meds and you're non-responsive? Or what about if you're going to be having to have some individual surgery coming up? How long do I have to be off of it? How long will I be safe? When will I be therapeutic? On a study on dabigatran, I had to answer a lot of those questions for people, and the answers were, well, here's what you were the last time you were in, and I had a physician specifically assigned to handle these type of questions. So it's a tough one. We don't have the tests that are FDA cleared, and the FDA doesn't seem to be in a big hurry because Big Pharma said that they didn't have to have this stuff monitored, just like they said the low molecular weight heparins didn't have to be monitored, just like they also said Plavix didn't have to be monitored. We now know that that's not necessarily true in all situations. Next question.
Thank you, Mr. McGlasson. Let's see. The next question asks, my laboratory pathologists say that the anti-10A test is too expensive as related to the APTT test. What do I tell them?
I advise you to take this presentation back with you and show them the dollar figures and take the reference that Dr. Marler put in the Seminars in Thrombosis and Hemostasis 2017 article. That's Dr. R.A. Mahler, great clotter. Richard referenced some very good information in there on the actual cost, and if you can work with your vendor, I'm sure they'll bring it in line for you. And that's the best way to do it. Show them that you can do it equally and the advantages to it. Hope that answers the question.
Yeah, excellent. Thank you for that. Looks as though we have time for one more question today. This final question asks, which companies have the universal calibrator set and the liquid anti-10A reagents?
Excellent question, because one of them just came out with one. Diagnostic STAGO has the liquid reagent, and they have the universal calibrators as well as the individual calibrators. Siemens just brought out a liquid reagent with a universal calibrator, and IL has had it for some time, a liquid reagent with the universal calibrators, and they can be used on all of their instrumentation. And I haven't seen the issues of using another company's reagents on a different instrument, but frankly, most of them are adaptable to be put on, like if you've got a Siemens reagent and STAGO is furnishing you reagents, or you've got an IL system and, for some reason you're using a different one, which most places don't do anymore, but the situation does run up. It shouldn't make that much of a difference. Now, it will make an incredible difference on the APTT, but not on the anti-10A, as you've seen by the studies that we've shown you today. Is that the last one we had time for?
Yes, it is. I would like to thank you.
Could I give a little closing here? Thank you for your time today. It was a pleasure. It was a pleasure to talk to you, and I hope I was able to give you some information that could help you. If you want to reach me by email, you can reach me by davemcglasson@hotmail.com, all lowercase, one word, and I'll be glad to answer any questions that you have. Take care. Good clotting from here, folks. Talk to you later.
I would like to once again thank you, Mr. McGlasson, for his presentation. I'd also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through February of 2018. You will receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thank you for joining us, and we hope to see you again here soon at LabRoots. Goodbye.